Hello and welcome to each one of you to Debbie's Dream Foundation May 2025 Town Hall. On behalf of Debbie's Dream Foundation, I'm your moderator, Dr. Rutika Mehta. I'd like to point out some basic housekeeping rules here. If you do not have the chat or the comment area open, please go ahead and do so now. If you look below at the bar on your phone or your desktop, the toolbar, you should be able to select a chat icon, which will allow you to ask interactive questions. And we would like to receive feedback and your questions to make this session, town hall, as interactive as possible. And please do share any ideas or questions that may pop up during the session. And once you've identified the toolbar, please go ahead and put in where you're joining us from. And in the meantime, we'll go ahead and do some round of introductions. As I mentioned, I'm Dr. Rutika Mehta. I'm a GI medical oncologist. I practice at Weill Cornell Medicine in New York City. I've had the pleasure of working with Dr. Pimiento, one of our panelists here, for about 7 years at Moffitt Cancer Center before I joined Cornell. I've been extremely involved with Debbie's Dream Foundation, and I think they do a fabulous job in supporting patients and caregivers through the entire journey of diagnosis, treatment, and survivorship. And I will now hand it over to Dr. Cleary.
Hi, everyone. It is a huge honor to be here today. I'm just a huge admirer of Debbie's Dream. It really is a wonderful organization that has helped my patients tremendously. So I was very, very excited to be here. I'm a GI medical oncologist. I run the clinical trials at Dana-Farber for the GI group, and I'm also an associate professor of medicine at Harvard Medical School.
Dr. Pimiento?
Hello, my name is Jose Pimiento. I'm one of the gastrointestinal surgeons at the Moffitt Cancer Center. I'm very excited and pleased to be able to join you guys today and excited to be a part of this wonderful program.
Great. All right, so there are 2 polls during this town hall, and if we could go ahead and put the first poll up. So the first question is, which part of research interests you most here? Biomarker testing, clinical trial phases, treatment combinations, side effect management. All right, so we have the majority wanting to hear more about treatment combinations. Next would be biomarker testing. Next up is clinical trial phases, and then side effect management. Great. That's very helpful for all the panelists to kind of understand what would interest you most. So this is an exciting month. In June, we just wrapped up with our major annual meeting called ASCO, and there were some fantastic presentations at ASCO, which I think would be very valuable to discuss. And since we have both medical oncologists and surgical oncologists here on the panel, I think first and foremost, I'd like to discuss the major study, Matterhorn study. So just to give all our audience on the town hall here some background, Matterhorn study is a large randomized phase 3 study. It's a global study for patients that have localized disease, which means stage 2 to stage 4A, but no evidence of metastatic disease, and were considered to be eligible for surgical resection, which means surgery could be done for these patients. And there were 2 arms to the study. The standard arm being FLOT, which is a 3-drug combination of fluorouracil, oxaliplatin, and docetaxel, versus that plus the combination with durvalumab, which is an immunotherapy. And earlier last year, we had heard about some promising data coming with pathologic complete response, which means adding immunotherapy does help to shrink the cancer significantly to a point that all the cancer kind of just melts away. But at ASCO just last week, we heard about it's event-free survival data, which means what was the percentage of patients surviving without any evidence of progression of disease or recurrence of disease or death. So I would like to pose a question to Dr. Cleary as to what were his thoughts about some of the findings from the study, and what kind of excites you most in the next couple of weeks that you're going to see another locally advanced gastric cancer patient.
Thanks so much for that introduction. I thought this trial was incredibly exciting, and it really shows the progress that's being made in gastric cancer over the past few years. So just taking a step back, as you mentioned, we have the National Oncology meeting, ASCO, every June. Last year, a key trial called the ESOPEC trial really established a chemotherapy regimen called FLOT, perioperative FLOT, that you'll get before and after surgery as the standard of care, which was a big, big step forward. And then this year, we took another step forward by showing that not only is FLOT the standard of care, but adding immunotherapy to the FLOT, durvalumab, makes it work even better. And so the reason this means a lot to me is it's going to reduce the number of recurrences my patients have. And that's always incredibly frustrating to have a patient with gastric cancer go through surgery, chemotherapy, just to have the cancer come back. And so incorporating immunotherapy earlier, I really think is going to improve outcomes. So I'm incredibly excited about it. The next patient I see who has a locally advanced gastric cancer, that's exactly what I'm going to do. I'm going to do FLOT durvalumab with one important caveat, as long as I can get insurance approval, because it's not quite FDA approved yet.
That's correct. Dr. Pimiento, your thoughts about, as a surgeon, do you foresee any challenges with getting patients started on durvalumab along with FLOT, or any surgical complications that you may perceive with the addition of immunotherapy?
And not really. I'm pretty excited about these new treatment options. The only caveat that I have to say is that I think FLOT has been the standard of care for gastric forever, at least for like we call ever, but maybe a few years. But now esophageal comes into the fray, so you can think patients with esophageal cancer a little bit different. Still, the challenge when you got the data last year was that many of these patients, like you were conflicted because there was some data immunotherapy could be very effective when you provide them with radiation before surgery. This obviates that. So now we get the best of both worlds. We're going to give chemotherapy, we're going to give immunotherapy, not just that, but we're going to get better and better complete response rates where when we do the operations, the cancers are gone. Certainly adding any type of treatment, meaning immunotherapy or radiation, whatever you add new, will bring some new side effects and some things that were unexpected. There are a lot of immunologic events that can happen in these patients, and the only thing that the surgeon needs to keep in mind is that sometimes these patients do have problems in their adrenals or other organs that could be problematic if you don't understand about it. But for most patients, is at least the FLOT combined with immunotherapy is well tolerated. So no, I'm super excited, and I think this is going to be the beginning of some new treatment options, because it's very different than the rest of the GI tract. In the rest of the GI tract, we're still looking for special markers to see if the patient can get the treatment. We are looking for stage 4 to be able to offer immunotherapy, and I don't think that will be the case anymore once it's FDA approved. So I'm with you, Dr. Cleary. I'm super excited.
That's great. So there's a question in the chat by Suzanne. Would that immunotherapy be before or after surgery? So Suzanne, great question. Wish I had some slides to kind of show it to you, but the way the study was designed was it was chemo with immunotherapy before surgery. So you do FLOT 4 cycles and you do Durva 2 cycles because it's once a month. And then again, FLOT plus Durva post-operatively, again, same 4 doses of FLOT and 2 doses of Durva. And then durvalumab, that's the immunotherapy, is continued for another 10 doses as a single drug to complete 1 year of treatment. So immunotherapy is being offered both before and after surgery. And while before we used to tell patients a sandwich approach, you get 2 months before, 2 months after. Now the therapy is slightly prolonged, which is now you're signing up for almost a year long of treatment, again, provided there are no other complications. But certainly, as Dr. Cleary mentioned, has shown to improve recurrence-free survival, event-free survival. So that's why it's gathered a lot of traction. And yeah, I agree. I think I'm looking forward to finding, who's the next person that's going to be eligible for this treatment. But I hear you, insurance approval would be a little problematic until we have FDA approval. There is another question in the chat. Are there patients who you would not recommend FLOT plus Durva for? If so, what would go into that decision? Again, Sylvia, I think it's a great question. So that leads us to segue to another study that was presented. It's the Checkmate 577 study. Dr. Pimiento had kind of alluded briefly about it, that initially with esophageal cancer patients, we were doing preoperative chemo with radiation, and then patients who did not have a complete response at the time of surgery, nivolumab, which is another immunotherapy drug, was FDA approved to be given for 1 year. That drug was approved based on disease-free survival benefit, as we all know. But at ASCO, they presented some data on overall survival, and it was just interesting to see that when you look at the overall survival curves for PD-L1 positive versus PD-L1 negative, so that meant PD-L1 score of 1 or less, there was actually a detrimental effect of the immunotherapy in these patients. So that was a little surprising for me to see. There have been times when we say, oh, well, if it doesn't work, it doesn't work. It's not going to do any harm. But this is actually another study that shows that, in fact, there could be some harm in treating PD-L1 negative patients with immunotherapy. Having said that, these are two different clinical trials. We don't have that granular data from Matterhorn study to be able to say, did PD-L1 negative patients have a detrimental effect or less benefit from the addition of durvalumab? But that is something that will probably be in the back of my mind when I'm making that decision of whether to offer durva or not. I'd like to hear your thoughts, Dr. Cleary, about this. What are your thoughts? How do you kind of make that decision? Even in the metastatic setting, people have gone with a cutoff of 1, 5, no cutoff. What are your takes on PD-L1 testing, PD-L1 scoring system, and the use of immunotherapy?
Great question. And just as full disclosure, I'm one of the authors on the Checkmate 577 trial. And I have to say, I totally agree with Dr. Mehta. I think for a while, this was the standard of care. So when patients had a GE junction adenocarcinoma, the standard of care was to give chemoradiation beforehand, then do surgery, and then give adjuvant nivolumab. But now, especially with the FLOT data looking so good, and now with the durvalumab FLOT data looking so good, I think the standard of care has really shifted to what people are now calling DFLOT, durvalumab and FLOT perioperative. But to answer the question, I think there is still a role. I think for patients who have a marginal performance status and you're worried about, because FLOT's a tough regimen. I think it's important to say that FLOT, it's a 3-drug chemotherapy regimen. So for people who have done chemotherapy, I usually think a 2-drug chemotherapy regimen like FOLFOX is hard, but a 3-drug regimen, boy, is that hard. And so for patients with a marginal performance status, I do think there's a role for doing chemoradiation before surgery than just doing adjuvant nivolumab, because it is easier to tolerate. But Dr. Mehta made a really important point. In addition to having, I will give patients with a marginal performance status that regimen, but I'll only do it if it's PD-L1 positive. And I think that's really, really important. I think that's also what the data is showing. And then to get to your question about PD-L1 in a metastatic setting, it's such a tough area. There's a lot of controversy. I think everybody agrees that if the CPS score is 5 or greater, that for first-line chemotherapy in a metastatic setting, you give chemotherapy, typically something FOLFOX along with nivolumab. It gets tougher, 1 to 5. I typically give it, my rationale being that PD-L1 is a very dynamic biomarker. So if you check multiple times, you can get multiple answers. And that's really the one chance my patients have to get immunotherapy. And I've seen some really wonderful outcomes with immunotherapies. I always feel like I owe it to my patients to give them a chance at that. So in the metastatic setting, I give anything PD-L1 1 or higher, I give the nivolumab.
Yeah.
So the only thing I could probably add is the fact that as a surgeon, I think I see life a little different. I see life basically in opportunity lost or cost of things that you're doing. So while we're talking about performance status, sometimes it's kind of nebulous, but the way I think about it is you need to consider which patients are going to benefit from multimodality therapy. So if you are not strong enough to receive more than one therapy, or if you are just there, but maybe not great, then you are going to start to having to have trade-offs. Trade-offs in which you're going to give less chemotherapy or immunotherapy, or you clearly know you're not going to end up having surgery. So in those situations, then clearly thinking and giving a combination of 3 chemotherapies plus immunotherapy and be sure that somebody's going to end up having surgery is quite hard.
Yeah.
So really the first thing that one needs to consider is performance status, how healthy somebody is, and the capacity to withstand what we're going to do to them. So it's kind of a marathon. So if you are not healthy enough to have it done, it's problematic. So what I advise everybody is as soon as I meet them, they need to get back to as good performance status as possible. Meaning if they used to exercise, they used to walk, they used to run, they used to whatever, just to get back to something. Because that is what is going to protect you, and that is what is going to give you the best chance to receive as much therapy as you can receive or as you need. In the other hand, whenever we talk about multimodality and resectable disease, we're talking about patients that are going to be ended up in surgery, and some patients just cannot. So in people that cannot have surgery, this combination of treatments may not be the most adequate because this combination includes the starting point and the end point that you're planning to do surgery. So if you are not planning to do surgery, then this combination will not be part of it. And I think you guys can talk a little bit about with the high incidence of autoimmune diseases, if that makes you pause in anybody to do immunotherapy in the neoadjuvant setting, because not infrequently you deal with that.
Yeah. No, I think Dr. and Dr. Pimiento are making both excellent points that one key factor when we're looking at patients, I think key takeaways would be number one, when you see a locally advanced disease, make sure that the patient sees surgeons as well at the same time, because that helps with the multi-D discussion of whether the patient can have surgery. Is the patient fit to undergo a major procedure like oesophageectomy or total gastrectomy? Is the patient eligible to undergo chemotherapy with 3-drug combination? Are there autoimmune conditions that would preclude them from immunotherapy? Then that way you kind of have to come up with a decision as to whether they are candidates for chemoradiation with definitive intent, or are they going to be eligible for perioperative chemotherapy, albeit be not a 3-drug, but a 2-drug combination? Sometimes we de-escalate from FLOT and give FOLFOX in those borderline candidates, but are still okay for surgery. So those are all the decision points. And having done this for a few years now, I can say it's not an easy one to make. But certainly larger places like Moffitt, Cornell, Dana-Farber, I think we're all kind of used to that multi-D discussion, which really helps take really good care of our patients and make sure that we're offering them the right treatment. That leads to a segue to another study, which was not focused so much on gastric cancer, but I thought it was very interesting to see. It was a trial that was done for colorectal cancer patients that had undergone surgery and were receiving postoperative chemotherapy. And there were two arms, patients receiving just a standard treatment with chemotherapy, and the second arm had exercise regime built into it. And interestingly, patients who had exercise along with their chemotherapy tend to have better survival. I'll pose a question to Dr. Pimiento because I mean he does this day in and day out surgeries and sees patients to assess whether they're fit for surgery or not. What are your thoughts about this, and can we extrapolate this into the gastric cancer space as well? Do you feel that exercise truly helps patients remain fit through their treatment? How would you incorporate such a thing in gastric cancer patients?
So thank you. That's an incredible point, and yeah, it's fascinating data. So when you think about exercise, data has been coming for years, especially in the survivorship world with breast cancer, prostate cancer, where there is clear data that patients that are in exercise regimes have less cancer recurrence. It is hard to know if there is a correlation or if truly is the exercise what makes the difference, of truly people that get involved in these regimens are in better condition and therefore the cancer doesn't come back. But there is data supporting that continuous exercise after surgery, after chemotherapy helps. So with this in mind, I think there is a smaller pilot, and we're doing currently one at Moffitt for gastroesophageal cancer patients when they have telemedicine directed strengthening exercise. The exercise needs to be of 2 points. One is some aerobic exercise, keeping walking, keeping moving, but it seems that it's more important at the long muscle strength training. So band training, light weights, about 2-3 times a week. And for some reason, that kind of training, I don't know if it's stimulation of certain inflammatory pathways or decrease of them, but it seems patients do better. Incidentally, when you get patients in this type of regimens of exercise, you tend to see them tolerating therapy a lot better. I don't know if it has to do with the fact that the pump of the heart is pumping oxygen, blood, chemotherapy all over better. I don't know if it's a function of just the patients that can do it do better, or truly we're changing the physiology of patients. But I see all the time that patients that from the start of diagnosis keep doing it, they do better. This is very poignant with gastroesophageal cancers because quite frequently one is afraid of doing any type of exercise because one is going to lose weight. So you are already having some limited intake. So what I advise people is just be sure that you maintain the liquid calorie intake as best as you can, and then incorporate some light exercise and some strength training to keep your performance. And what we tend to see is that those patients tend to do a lot better during treatment, less side effects, and they tend to be in a lot better shape at the time of surgery. And certainly when that is the case, they tend to do much better with the side effects of major operations. And I don't know, Dr. Cleary, you see the same on patients getting chemotherapy.
Yeah, I was incredibly excited about that data at ASCO. I think as Dr. Pimento said, I think it really validated a lot of data we've been getting in breast cancer and colon cancer over the years. But to see it done in a randomized trial like that, the trial design is really what was convincing here, is that one group was randomized to a structured exercise program, the other one wasn't. And the people who had structured exercise did better, did significantly better. So exciting. I can't pretend to tell you why that might be, but the data is really clear. It was a randomized study. And so I'm definitely going to be recommending this to all my patients with colon cancer. But to Dr. Mehta's point, yeah, I'm going to be recommending it to all my patients with gastroesophageal cancer. I do want to be careful, though, about my recommendation, because one of the things I loved about the trial is they were so smart. The exercise program started after the patient completed chemotherapy. Because the last thing I want to do is pressure one of my patients going through a tough time with gastric cancer on chemo and recovering from surgery to go exercise when they're not feeling they're able to. Obviously, if they're feeling they're able to, great, go exercise. But if you're not feeling you're able to, it's okay. You can just wait until after the adjuvant therapy is complete, after the chemo is completed, and then 2 months later, start the exercise. And the exercise also, it sounds like you have to go to the gym and get a trainer. No, it really was pretty simple that you can go out for a walk 45 minutes a day, 3 to 4 times a week, and that's enough. That would have satisfied the requirements of doing exercise on this trial. And I think all of us, oncologists included, could be exercising more. So 45 minutes, 3 or 4 times a week, going for a walk, I think it's great.
Yeah.
Well, you're nicer than I am. I'm not that nice. So you're getting chemo, you walk. You
Yeah.
are
I
get
think it's great if you can do it.
yeah.
Yeah.
Yeah, no, you have to. So I think the challenge that people get for these regimens that have surgery as a sandwich
Mm,
is that we count on people being good enough, being in as good of a performance status that they can be within a month of completing chemo.
mm,
So if and I know infrequently, especially for esophageal cancer patients or total gastrectomy patients, I see that is 2 weeks and they still don't look like they can walk. It's three
yeah.
weeks and they still don't look that they can walk. It's 4 weeks and they just barely start walking. So that means that the period of pause between the chemotherapy and surgery will be now 6, 8, 10, 12 weeks. So my advice is it's a lot easier not to lose your muscle than to try to gain it. So if you have a couple of bad days every cycle and you don't walk those days, perfectly fine. If you can walk 10 minutes, walk 10. If you can walk 20, walk 20. But if you can walk 30, 40, then do it. Just because trying to get to 30 or 40 minutes may take you 3, 4 weeks. And by then, it may be 5 weeks after a chemotherapy, and that will kind of delay. And the person that starts getting worried about things is your surgeon and second you.
Great. Yeah, I think my takeaway point is keep exercise during chemotherapy helps to metabolize those drugs, and there are probably lesser side effects. But emotionally, I also feel like when you're dedicated to doing some activity outside of just thinking about your treatment, about your cancer, you're much better to tolerate this emotionally as well. Because as we all know, having a diagnosis of cancer is not an easy process emotionally for, either the patient or the caregivers. So I always think of, having an activity on the side as just to take your mind off this entire process that's going on, which also helps for emotional well-being. Um, all right, I think we should do our second poll because I see a few questions that might be relevant in our second part of the conversation. So the next question is, which treatment approach interests you most? New immunotherapy combinations, targeted therapy advances, surgical innovations, supportive care strategies, clinical trials. All right. I don't see anybody else responding. So we have 10 people that have responded. So I think there's like a triple tie between new immunotherapy combinations, targeted therapy advances, and surgical innovations. And then secondly, supportive care strategies and clinical trials. Great. Thank you for that. There were a few other questions. Any new treatment changes and any of the standard of care for patients in stage 4 setting? Great question, Frank. And that I think points to one of our other presentations at ASCO. It was a study called Destiny Gastric 04. And just to give a background, Destiny studies are with FAM, trastuzumab, or Enhertu drug. And we already have Enhertu as an FDA-approved treatment for HER2-positive gastroesophageal cancers after they have progressed on trastuzumab-based therapy. But this was another randomized study for patients on second line HER2-positive, randomizing them to Enhertu versus ramucirumab and paclitaxel. So ramucirumab and paclitaxel was FDA approved back in 2014 after first-line FOLFOX treatment. So kind of having a head-to-head comparison. And we had a press release even prior to ASCO, which had shown that there was promising data. But Dr. Cleary, any thoughts about that? And what would you tell our audience about Enhertu in the second-line setting?
Yeah, I think an encouraging direction that gastroesophageal cancer has been moving in for the past few years is just biomarker-directed care. That it's really, really important when you get a patient diagnosed with metastatic gastroesophageal cancer that you look for biomarkers. Is the patient's tumor MSI high? Great, you can give them PD-1 directed therapy. Recently, we've had another one, Claudin 18.2. You might consider zolbetuximab, but then here, if it's HER2 amplified, we have some great options. A couple of years ago, a trial out of Memorial Sloan Kettering showed that if you have a HER2 amplified tumor in the first line setting, you can get FOLFOX, immunotherapy pembrolizumab, but also trastuzumab, which binds to HER2. And that's really just been wonderfully effective. But the trial that Dr. Mehta is talking about that we're all excited about is we could continue to go after HER2. So even though we target it in first line with FOLFOX, pembrolizumab, and Herceptin, what this data is showing us is that we can actually continue to target HER2 when we give an antibody again against HER2 that has chemotherapy on the back of it, something called an antibody drug conjugate. I think one important thing that I really just want to get across is it's really important when you have a HER2 amplified tumor, when you're going to try HER2 therapy in a second line, to just confirm that HER2 is still amplified. One way that cancers can kind of get around therapy is you can lose that HER2 amplification. So it's really, really important to just have your doctor look to see if HER2 is still there. But if HER2 is still there, yeah, I'm awfully excited about using Enhertu. I think it's great therapy.
It was exciting to see that finally put to rest that we could continue in HER2 or give HER2-directed therapy in the second line setting. All right, we're still going to continue with questions. We're done with poll right now. So there's a question by Lissa which says, what is the reason FLOT is not an option for in non-perioperative, meaning non-resectable setting? Yeah, Lisa, that's a great question. So as Dr. Cleary was mentioning, FLOT is an exceedingly difficult treatment to tolerate. And when it comes to side effects, we see a multitude of side effects: bone marrow suppression, hair loss, neuropathy kind of doubles up because you're having both docetaxel and oxaliplatin causing neuropathy, fatigue, nausea, vomiting. So those are all the added side effects by just another drug added to it. But most importantly, as Dr. Cleary was just mentioning, we have so many biomarker-driven therapies now, and we are trying to segregate our patients based on those biomarker status. And our hope is to try to embark on those biomarkers and try to have advantage of those biomarker-driven therapies and reduce the side effects rather than escalate the chemotherapy and give more side effects. So that's my take on, how I treat a, stage 4 patient in the first line setting. I feel it's more of a marathon rather than a sprint. So if I know if the patient needs to continue this for a long time, I might as well cut down on the side effects and make sure that the patients are tolerable treatment over a longer course of time. And it would be much better if they have a biomarker-driven therapy, because then I can bank on the biomarker-driven therapy and try to get advantage of that. Dr. Cleary, any thoughts on that?
I totally agree. There was a recent trial that showed that FLOT is very active in the metastatic setting and might even be in some ways superior to just giving FOLFOX. However, as Dr. Mehta just said, first of all, FLOT is just really, really hard. So is it worth that small advantage in efficacy because of all that toxicity? But also, and really what cinches it for me is there's so many other biomarker-directed therapies. So like Dr. Mehta said, I view this as a marathon, and I really don't want to beat my patients up with FLOT because I really just don't see that it gets me more. So I really prefer doing FOLFOX and combined with biomarker-directed therapy.
Well, what do you do when you don't have any biomarkers? You just have nothing. So you have CDH1 low on claudin, and there is no other options. I can't get into clinical trials because I don't have measurable or even evaluable disease. I have Mets to the bile duct, which is, another issue in itself. I know that's very rare. And having this subset of diffuse gastric cancer really doesn't leave me with any other options. And I'm just wondering if that is too personalized.
So there is a large phase 3 trial ongoing. It's a cooperative group trial through the NCI, the triple gastric trial where we're looking at FOLFOX versus FOLFIRINOX. So again, slightly different than FLOT. Again, there is no data out yet, but that could be a potential study to look into. It doesn't require measurable disease for that trial.
Well, that's good. It's a start.
Yes, it's stratified based on PD-L1 status. If you're PD-L1 negative, then it's either FOLFOX versus FOLFIRINOX would be the randomization.
Yeah.
But I hear you. Yes, if there are no biomarkers, it all depends on, what's the burden of disease, and do we think it's low burden of disease that where you could do in a few months of maybe an aggressive treatment combination and then probably de-escalate once you have, maximal response achieved. That would be one consideration.
Can I expand on the question with Dr. Pimiento?
Yeah, certainly.
Oh, thank you so much. So in that case, I know, diagnostic laparoscopies, they don't like to do them unnecessarily because they feel it won't change the course of someone's treatment. But if you're looking for possibilities of markers that have changed, or maybe new markers, FGFR, B, whatever, and looking for new markers and maybe can do RNA assay, is that a reasonable time to do another diagnostic laparoscopy?
So there are two different lines on that question. So the first one is, why not to just start with FLOT?
Yeah.
Well, because if you get 4 months of FLOT, that may be all the chemo you ever get.
Okay.
Like some people get 4 lines of FLOT and that's so if you see in the clinical trials, 60% of people stop getting chemotherapy after surgery. So they go 2, maybe 3, and end of discussion, like 3 months, I mean. So the reason why we don't do 4 is because a lot of people, after we go in the 3rd month and we're going towards the 4th month, are done. The bone marrow cannot work anymore, so we cannot give them chemo anymore. So the question is not why we're withholding good therapy. No, the question is, what is our goal? And if our goal is long-term survival, best outcomes possible, then we need to be smart and treating you with stuff that is going to be able to be given to control the cancer, to make this a chronic problem. So if the second question is, how can we know if the cancer is still active? Well, there are markers in the blood, there are liquid biopsies that can be given, there are also just endoscopies. So if you still have a cancer in the stomach, then you can, at that moment, do a biopsy in the stomach that is a lot less complicated than doing a laparoscopy. Laparoscopies can be repeated, certainly. Trying to do biopsies around the peritoneum in the biliary tree is something that people will not do, just from the chance of causing an injury to the bile duct or something. And if that is the case, then you won't be able to get more chemo. Because if you have a complication, an infectious complication, you will not be able to receive any therapy. So again, everything is a combination of what is reasonable, what is going to give you answers, and what is going to allow you to have longer best outcomes possible. And sometimes that is really hard to convey to people because people think, okay, well, why don't we do this and this and that and this and that? Well, because when we used to try to do those things in the past before chemotherapies were very effective, these type of cancers used to be thought to be completely lethal, and they used to be thought to be cancers that you couldn't treat. And it's not really that you couldn't treat, it's that we were doing the wrong thing. We were resecting things that we shouldn't. We were leaving cancer behind when we shouldn't. We were doing partial resections and telling people we almost got everything out, so you should be happy, and actually well, that's nothing. So yes, a laparoscopy is possible, but if there are other ways like the blood, like a liquid biopsy or an endoscopic biopsy that is going to be able to acquire tissue and see tumor markers, that would be easier. Laparoscopy certainly can be done as long as the original operation wasn't done open. If the original operation was done open, then the challenge, if you had an operation, then the challenge is that when you go back, you can occasionally have a bowel injury, or you cannot see anything and not get to where you want to be. So in those situations, you can spend 3-4 hours and just be working in doing cleaning of scar tissue. Not just that, but for an operation, not infrequently, you need to be off chemotherapy for 4 or 5 weeks before surgery and 4 or 5 weeks afterwards. So again, it depends on what the goal is. So if your goal is to finish a sprint, let's use all the calories in the first 100 meters. Of course, that makes sense, because the goal is to finish these 100 meters. So that is chemo, surgery, chemo. Of course, let's go quick. And then if you don't finish and you just have that at the end, who cares? You like, we did 100 meters. Well, you need to do 10 miles. You need to do 25 miles. So how do we get through 25 miles? Well, we don't go crazy the first 5. We just go very methodical. We just go, okay, so how are we going? Okay, so what are we dealing with now? And then the person that should be able to counsel you on that is your treatment team. And that is why you need surgeons involved in the treatment team. That's why you need medical oncologists involved in the treatment team that have your best interest at heart. And again, a laparoscopy can be done if you had a surgery that wasn't done open the first time. If it was done open, we have seen patients that come to us after somebody tries to do a laparoscopy or tries to resect something or tries to remove something, and then they just cannot get chemotherapy anymore. And then we're very saddened, because we went from a situation where we were very controlled with very low tumor markers and patients been getting one dose of one chemotherapy agent for 6 months. Now with situation where they are unable to receive any treatment anymore. And that just breaks your heart.
Oh, sure. Well, thank you very much. Thank you, everyone.
So in light of some other advances in the stage 4 setting, again, not directly related to just to gastric cancer, but there was FDA approval for Opdivo or nivolumab as a subcutaneous injection. And it's interesting because we frequently use nivolumab in the metastatic setting, or if patients were treated with chemoradiation, then as adjuvant nivolumab. But the question now comes is, what's the best way to use a subcutaneous formulation of immunotherapy? I personally haven't yet treated any patients with subcutaneous formulation, but I do have some thoughts in mind. But Dr. Cleary, any thoughts about subcutaneous nivolumab, and how you might probably put that into practice if you found an appropriate patient?
Yeah, I haven't used it yet, but I have no doubt that it's equally efficacious. So I don't have any concerns about its efficacy profile or the side effect profile. I think one thing it makes me think of is one thing that's not talked about enough is the time cost of having cancer, the time cost for the patient driving back and forth to the clinic, but also to the family. It's just a lot for family members to come back and forth. And giving the sub-Q injection of nivolumab, perhaps that would minimize some of the time costs, get them out of the clinic faster. So I could see an advantage in that way. But my institution has not started using it yet.
Yeah, we recently, incorporate that into Epic, which is our EMR system. Some of my colleagues in cutaneous have started using it, but I would think if patients were on, say, for example, FOLFOX plus nivolumab and had an excellent clinical response to treatment, and there was a time to de-escalate and take them off chemotherapy and keep them maybe on maintenance nivolumab for some time, that would kind of be one of the situations or scenarios where I might consider doing the injectable, the subcutaneous nivolumab. But hopefully we'll start to see more of these.
Yeah, I think as it becomes more clear than some of the adjuvant treatments are here, and this is an option. I think some people are going to take advantage of it, but we really need to
Yeah.
be sure that it's going to be delivered correctly, and that we really understand how it's done. We in GI we haven't done it.
Um, I don't know if Lawrence is still on the call, and if you'd like to present your question, or otherwise I'm happy to read the question myself and try to answer. But if you'd like to share your story with the rest of the group, that would be great as well. Do we still have Lawrence on the call? Okay.
It says read, please.
Oh, okay. All right. I will do that. So the question is, nodal recurrence in early 2024, started treatments last April and still on maintenance treatments, so 5-FU and Keytruda until today. Recent ctDNA went up from 8 to 30. That's what I'm assuming that is. Is this considered significant? Want to start exploring options before things start to show on scans? Can I switch Keytruda to PD-1 plus CTLA-4 combination like nivolumab plus IPI? I feel like immunotherapy did a good job for keeping me this long since last year. My CPS tested for 5 and 20 last year. TMB is 13. Is it possible not to drop immunotherapy if I will be on second line of treatment? Thank you. Dr. Cleary, what would you advise Lawrence in this situation?
Yeah, it's a great question. First thing I would say is we were talking about exciting things coming up in oncology, and I'm assuming this isn't an MSI high tumor, but I wasn't exactly sure. If this was an MSI high tumor, one thing we're incredibly excited about is Werner's helicase inhibitors, and those are in phase 1 trial, and there was some really high profile scientific articles that showed these Werner's helicase inhibitors work really well, at least in animal models of MSI high tumors. And so there's a lot of enthusiasm that they're going to work in PD-1 refractory MSI high tumors as well. So if this was an MSI high tumor and there's clear radiological progression, that's what I would think of. And that's really kind of getting to my answer. If this isn't an MSI high tumor, if this is just a microsatellite stable tumor, even though the ctDNA is going up, I would wait, because sometimes these markers can be a little fickle. So I would definitely wait until I saw a radiological progression. But when there was clear radiological progression, I would take the patient off the pembrolizumab and the 5-FU, and I would think about something like Taxol ramucirumab or a clinical trial for second line.
But so I think the only caveat there is what would the imaging show? So if you were to be dealing with like a single local regional node, or if you were to be dealing with something that is more in the local regional space, or maybe an isolated a long nodule or something like that. Sometimes um, one can think in more local regional treatments before escalating, or you can escalate to a clinical trial. But really, the context of the findings is very important.
Yeah. And I think I would just add to it, depending on how long it's been since you stopped maybe oxaliplatin, there could be a role to just reintroduce the oxaliplatin for a little bit and see if you could restore that response before kind of totally giving up on this first line treatment. The combination of PD-1, CTLA-4, and adenocarcinomas that are not MSI high, again, has not panned out as well as we hoped it to be. Um, Again, it might be the dosing and everything, but we still don't have a great handle on doing a dual checkpoint by itself without any chemotherapy backbone for non-MSI high adenocarcinomas. All right, I think we have a few more. We have 6 minutes left, so okay. Sylvia's question is, should a patient forego EUS if total gastrectomy is already planned? Is there utility for surgical oncology? Dr. Pimiento, would you like to answer that?
So US, in my mind, an endoscopy and US by extension has similar function. And I think it's important to do it in a place where people are very facile and they understand what the objective is. So what you want to do with the US, number one in my mind, is to clarify the proximal extent of tumors. So you occasionally have proximal gastric cancers. That means cancers that are sitting in the top part of the stomach that extend towards the esophagus. I hate surprises. I really, really dislike surprises. My birthday was recently and I didn't want a surprise. So I don't want a surprise in the OR either. So if you can figure out how high the tumor is going into the esophagus, then you can have a plan. You can see how much esophagus you have to resect. At the same point, if you are so in your plan gastrectomy, regarding neural disease, I think the value is more limited. If you were to tell me it's clear that a total gastrectomy is planned, the cancer seems to be proximal stomach but not involving the esophagus, and I already know there is lymph nodes, I think an EUS is less important. However, and not infrequently, the original endoscopy that was done where the biopsies were obtained wasn't done with planning of surgery or planning of treatment in mind. It was just done because you were bleeding, you had belly pain, you had nausea, early satiety. So a lot of the times the information of what is found, skip lesions, significant Barrett's esophagus, other things that could impact your surgery were not taken into consideration because it was done just because people were having belly pain or something. So I like to have more complete information, but if I'm already planning a total gastrectomy and I know the cancer is not extending into the esophagus based on imaging, based on PET scan, and based on the CAT scan, then I don't think it's a must. But if I'm not sure, or if the original endoscopy wasn't very clear on the anatomy, I prefer having one.
That's good to know. I think we have last 4 minutes, and I'd like to just kind of try to start wrapping up. But Dr. Pimenta, one question that, often comes up is after surgery, do they really need to follow up with the surgeon? And what would be the utility of following up with the surgeon? I try to reiterate this with my patients again and again, but would love to hear your thoughts as a surgeon. Do you feel like, oh, I've done my surgery, my job is over, I don't need to see them, the medical oncologist can handle everything, or would you rather see them and follow up?
Well, I tell my patients that the best utility is they get to see me. So I get to see all this. So, that is always like a plus. No, in reality, I think I see my job in the adjuvant, like after surgery, in three different buckets. The first one is to be sure that whatever the patient is experiencing is normal. The food-wise, side effects. Some side effects happen early, some side effects happen late. When people are getting chemotherapy after surgery, it's not infrequently that you get side effects and you don't know if they are related with the chemotherapy or related with the operation. And sometimes they start appearing when they advance their diet after they completed the chemotherapy. So I do a lot of that just to have a conversation. Just to be sure that that patients understand this is normal, this is not normal, these side effects are expected, these are not expected, and how are they to change. So after a total gastrectomy, I expect weight loss for 6 months. Then it continues to kind of level off over 1.5 to 2 years, and then at 2 years you start seeing weight gain. So when I keep telling the patients that, then it's reassuring because they understand. The second, diet, normal versus abnormal, and the third part is that you get to be sure that somebody's keeping an eye on things. So sometimes people go on vacation, insurance change, and if they don't have more than a point person for follow-up, it's quite frequently that I get a call a year out asking, well, what do we do now? I haven't done an x-ray for a year. And then I go like, what happened? Oh, my insurance changed, my doctor left. So especially in the first couple of years after surgery, it's a good idea to have more eyes we completely defer to a medical oncology during chemotherapy and in the period right after. And for what is necessary for surveillance, I 100% defer to my medical oncologists. They are awesome. And then, be sure that somebody's keeping an eye on things, just so people don't get lost in follow up. But I really think it's important, and I like to see patients up to 5 years, just to be sure that whatever side effects, and then later when I start having to yell at them about weight gain and they start to get bigger, and you go like, man, dude, like get back to exercising and whatnot. This is better for you. Then it's always good to hear it from the surgeon.
That's great. It's great to know your perspective. Dr. Cleary, the last minute, what are your, takeaways from ASCO, and what are some 3 practice changes that you're going to be making in your clinical practice?
Great question. I think the thing I'll be doing for all my patients, just echoing what Dr. Pimiento just said, is just trying to get them exercising. The story I was going to say is I have this wonderful patient who's in his 80s and is still out there exercising every day, and has had gastric cancer, for at least 5 years, metastatic, and been doing great. So, I think exercise is a wonderful thing. I think the flat durvalumab, like we talked about, is also incredibly exciting. And then the final thing, I think there are some emerging therapies in gastroesophageal cancer. One thing, there was a question in the chat about new immunotherapies, and in liquid tumors like lymphoma, multiple myeloma, and leukemia, there's things called CAR T cells. We've been frustrated that they haven't worked great in solid tumors. Well, there was a trial in gastric cancer that's starting to give a little optimism. I think it's too early to say, but at least made me feel better about the field and making me think we're moving in the right direction.
That's great. Suzanne, I know you have a question and we're out of time, so I'll quickly answer. My typing wasn't as fast enough. But after last chemo, last chemo was on 6/10, scan scheduled for 6/20. How much time after scan should surgery happen? What is the most time to wait for surgery? Typically 4 to 6 weeks is ideal, barring any other side effects that haven't recovered. So as long as your surgeon feels like you're fit for surgery and you have no lingering side effects, and 4 to 6 weeks is the ideal time. Hope that answers.
But you need to be healthy enough.
Yep.
So if you need longer, you need longer. So that the optimally 4-6, if there is radiation involved, you are going more 6-8. But if you are not healthy enough, at best is to wait. You cannot rush being ready.
Yeah.
So as long as you are ready, that is the optimal time. But don't try to like push it, because I see people like really pushing it and they are not ready, and then they end up depressed because you think that something bad is going to happen if you wait another week. Well, not really. Like we work in weeks, but the cancer doesn't. Like we see awesome responses with people that have it at 4, at 5, at 6, at 7. So.
And I think always communicate back with your medical oncologist if there is a delay in having the surgery scheduled, because you might want to take advantage of that time and maybe get a couple of more treatments in. So always have that communication back and forth. But I think this was a very interactive town hall. I do appreciate both Dr. Cleary and Dr. Pimiento for being so proactive in their answers and for just giving such candid responses. I think this is almost like a multi-D setting where we're talking about what we would do with our patients. And I think all the patients and caregivers were absolutely fantastic in raising some great questions. Even at 9 p.m., 8 to 9 p.m., where I'm planning to go to bed, I'm still thinking about data that was presented at ASCO. So, of course, it was a very exciting ASCO for, GI oncologists. And I look forward to collaborating again with Debbie's Dream Foundation, and probably hoping to see some of y'all again in another town hall or another meeting. Thank you so much. Have a great night.
And you know what is the best part, Dr. Mehta? That I got upgraded to medical oncologist. So now I'm going to start ordering chemo, like beware.
Now you can start prescribing chemo. Thank you, everyone. Have a good night. Bye.
Thank you.